Hello doctors. Today we are going to discuss another topic of pediatric surgery, that is infantile hypertrophic pyloric stenosis. So this infantile hypertrophic pyloric stenosis was first completely described by Hirschsprung in 1888. And he have given the name of congenital hypertrophic pyloric stenosis. Previously the name was congenital hypertrophic pyloric stenosis, but now the name has been changed from congenital hypertrophic to infantile hypertrophic. Why? Because two scientists, one is Walgren, another one is Rollins. Walgren have done an experiment on 1000 newborn with normal pylorus thickness and pylorus length and diameter, but out of which 5 of them developed IHPS later on. And Rollins have done an experiment on 1400 normal newborn, but 9 of the newborn have developed IHPS later on after 4 weeks. So it suggests that the hypertrophy of pylorus or length of the pylorus is not the thickness of pylorus is not increased from congenitally. It have increased after some times, and there are some factors which are influencing them. So the name was changed from congenital hypertrophic pyloric stenosis to infantile hypertrophic pyloric stenosis. Now incidence, we will know about the incidence. Most common surgical cause of vomiting in infants is IHPS, and it is 1 in 3,500 live birth in India, and incidence is 1.5 to 4 of per 1000 live birth in all over the world. Male is to female ratio is either 2:1 to 5:1. So it is more common in males. Remember this point, very important, and affects the firstborn male child around 2 to 4 weeks of life. It affects the firstborn male child. And there is recurrent non-bilious vomiting present, curd-like vomiting, projectile vomiting present. Projectile vomiting, and this is non-bilious vomiting. And remember, the bilious vomiting occurs in duodenal atresia. Okay, in duodenal atresia we have the bilious vomiting. And in how will you differentiate between duodenal atresia and IHPS? In duodenal atresia, in duodenal atresia we have bilious vomiting, in IHPS we have non-bilious vomiting. And IHPS, the symptoms of IHPS occurs around 2 to 4 weeks after birth, and in duodenal atresia it is generally within 1 week of birth. This happens in duodenal atresia, that is bilious vomiting and here non-bilious vomiting. Now etiologies of IHPS. 6 etiologies are there and you have to remember them. So number 1 is genetic etiology. First we will start with the genetic. Genetic may be familial or inherited genetic syndrome, or there may be Smith-Levy-Oppitz syndrome. So these are the genetic symptoms in which genetically the CHPS or IHPS can get transmitted. Then number 2, we have the environmental factors. In environmental factors, it depends on the method of feeding, milk feeding, how the mother is feeding the milk to the child. The method of feeding is important. Apart from that, erythromycin exposure, maternal smoking, and young maternal age. If the mother is young, very young and giving birth to a child, then also the child might develop IHPS. And apart from that, remember this has been asked many times in MCQ, that is erythromycin exposure. This is asked in MCQ many times. And maternal smoking is also important. Now number 3 is mechanical. Mechanical means there is disturbance in either gastrin, substance P, epidermal growth factor, secretin, somatostatin, or insulin-like growth factor 1. These factors can also affect IHPS, and it has been proven. Number 4, which is most commonly, and we have been reading this from our undergraduate time, that is lack of nitric oxide synthase, because lack of nitric oxide synthase also causes IHPS, and this is the most common hypothesis which is accepted. And number 5 is neurotropin, which are decreased, like decrease in interstitial cells of Cajal in pylorus, or if there is tyrosine kinase A receptor, decrease in tyrosine kinase A receptor, or if there is glial derived growth factor decrease and heme oxygenase 2 decrease. These factors, if get decreased, might cause IHPS. This is 5th, and the last 6th one is lack of NADPH diphorase activity in hypertrophied circular muscle. If in the circular muscle there is decrease in NAPH, NADPH, diaphoresis. This is the sixth point. So there are 6 main etiologies that you have to remember. One is genetic, environmental, mechanical, lack of nitric oxide synthase, neurotropins, and lack of NADPH, diaphoresis. So these are the 6 factors what can cause IHPS. Now we have the clinical features, how the child will present. I have already told this to you. There will be a non-bilious vomiting and projectile vomiting in 2 to 8 weeks of life, and there will be dehydration because of vomiting. All the fluid is going out, so there will be dehydration and child will be lethargic. Now remember this point, this is very important and asked in MCQ also. That is, if there is jaundice, if the child have jaundice in IHPA, generally jaundice doesn't happen, but if there is a jaundice, 2 to 5% chances of jaundice is present. It is due to deficiency of glucuroline transferase deficiency. Because of this deficiency, there is jaundice in IHPS, and this is asked many times in MCQ, so remember this. Now, differential diagnosis. Differential diagnosis are of IHPS is GERD, pylorospasm, gastroenteritis, metabolic diseases, antral web, pyloric atresia, gastric volvulus, gastric duplication cyst. These are the some of the differential diagnosis of CHPS. Now, diagnosis, how will you diagnose this case? We have seen the clinical features. One is by clinical feature you can suspect whether it is bilious or non-bilious, so what is the level of obstruction. And another one is visible peristalsis may be seen in child. In that can also, we can also suspect at the time that child might have IHPS. Apart from that, child will have hypochloremic, hypokalemic, metabolic alkalosis will be present. Remember this, hypochloremic, hypokalemic, metabolic alkalosis, and it is frequently asked and everyone should know that. So this is an important thing to know. And there will be hyponatremia also. Fine, there will be hyponatremia also. Now, gold standard for diagnosis is now ultrasound of whole abdomen. If we do ultrasound of whole abdomen and if we get pyloric muscle thickness of 3.5 to 4 mm, then it is sure that there is hypertrophic pyloric stenosis. Or if the length of the pylorus is more than 14 mm, then also we can diagnose that the child have IHPS. And another study that was done previously, that is upper GI contrast examination via the barium swallow and barium meal. That is, we can see string sign, beak sign, and shoulder sign. So these are the string signs. String like appearance is present here. String sign, beak sign, or shoulder sign is seen in upper GI contrast study, but this study is not done nowadays because upper GI contrast study causes aspiration pneumonitis. Fine, aspiration pneumonitis. Upper GI contrast study can cause aspiration pneumonitis. So therefore, the gold standard for diagnosis of IHPS is ultrasound of whole abdomen. Remember this. Now, management. Preoperatively, first we have to correct the fluid and electrolytes. That is, according to Benson and Alperon classification, we classify the IHPS via the serum carbon dioxide level. What is the serum carbon dioxide level? According to that, we will classify IHPS. If it is less than 25 milliequivalent per liter, then it is mild. If 26 to 35, then it is moderate. And if it is more than 35 milliequivalent per liter, then it is severe IHPS. It is according to serum carbon dioxide. Fine. Now, operative procedure. Operative procedure, we have 2 main procedure that is done. Gold standard is Ramsted pyloromyotomy, because this was first introduced by Ramsted. And in this procedure, either we can give a transverse incision. First, it was transverse incision was given over abdomen, and then pyloromyotomy was done. But now supraumbilical incision is given. Supraumbilical incision was given. This is Tan and Bianchi modification. Why supraumbilical incision is given? Because supraumbilical incision have good osmosis. Fine. Because of that, there is supraumbilical incision is given today in Ramsted pyloromyotomy. This is Ramsted pyloromyotomy. This is the thick pylorus, as you see in the red color, and thick pylorus muscle is myotomy is done, and then easily the food can pass into the duodenum. So pylorus muscle are just cut out. Now, another method that is used nowadays, that is laparoscopic pyloromyotomy, that is by Allen and colleagues. Since 1991 it has been introduced that laparoscopic method should be used for pyloromyotomy. So there are advantages of laparoscopic procedure and disadvantages of laparoscopic procedure. The advantages are it have shorter recovery, patient will recover easily and go home, and there will be less use of analgesics, pain will be less. Okay, less use of analgesics. And disadvantages, there will be, it might have incomplete pyloromyotomy. Why incomplete pyloromyotomy? Because while doing open procedure we use our hand, so we have the tactile sensation, but when we are doing lab we do not have the tactile sensation, so there might be inadequate pyloromyotomy that can be done because we are not feeling the pylorus muscle through our tactile sensation. Therefore there might be inadequate pyloromyotomy in cases of laparoscopic pyloromyotomy, and there might be more chances of duodenal perforation in cases of laparoscopic procedure. It had, after many studies, it is still at some point gold standard is Ramsted pyloromyotomy, because it has been seen that it has slightly better outcome than the laparoscopic pyloromyotomy. So still the gold standard is Ramsted open pyloromyotomy. Now post-operative feeding. Post-operative feeding can be started as early as 4 hours post-procedure. After 4 hours, if the mucosa is not injured, then we can start feeding within 4 hours. But if there is any kind of symptoms of gastritis, then we wait for the gastritis to settle down for 2 to 3 days, and after 2 to 3 days we can start the feeding. And the complication, what are the complication? Complication is persistent bleeding, and then persistent vomiting may be present, and wound related infection. Why persistent vomiting? Persistent vomiting may be due to unsuspected perforation may be present, or incomplete pyloromyotomy is done, therefore persistent vomiting may be present. And wound related complication like wound infection, and generally reoperation is done in only 6 to 8% of cases. Reoperation is done, like we have to again do the pyloromyotomy. Apart from that, this IHP has have a good prognosis and good outcome after surgery. Thank you for watching, guys. Please do like, share and subscribe to my channel so that I can make more free videos for all the medical students out there. Thank you.